Respected medicos, welcome to the series of surgery lectures by Dr. G.R. Patel, myself Dr. G.R. Patel, ex-professor of surgery, and I have the teaching experience of 28 years. Today, I have selected a topic which is a bit out of the context, but it is necessary. We all are prone to mistakes. We all fumble sometimes during our surgical career. So I wanted to highlight to have no place for any complacency, any doubt in our subject. And when we are teaching the patient, we have to realize that these mistakes are not pardonable, they are irreversible, and it might cost us, we might have to pay heavy price for our mistakes. So let us start. I have worked in so many hospitals. My previous experience as a surgeon, as a teacher, as an examiner, I have collected some very important points which I believe I must highlight and brought to the medical fraternity so that they cannot do the same mistake again. To work with a fresh mind, the surgeon or the consultant or the clinician works in the OPD with his maximum concentration. He wants to do no mistakes, nothing should be missed, that is his aim. The surgeon puts in his everything. Knowledge is power. The surgeon works to the point, usually doing spot diagnosis. The ABCD rhythm rushes through his mind. The consultant tries to keep himself always free for the next emergency. He is very likely to miss the most important diagnostic feature. Few examples. Say history of conversion. Patient is brought to you with the history of conversion. Is it hysteria or is it grand mal epilepsy? Take So how will you decide? Take plantar reflexes. If it is positive, that is extensor, means the conversions were due to grand mal epilepsy within last 24 hours. If it is flexor, you can surely say the conversions were due to the hysteria. The slow release of ankle jerk is pathognomonic of hypothyroidism. Presence of vascular blurring is pathognomonic of Graves' disease. This is what we learn from our seniors. Staff nurse takes order round in the routine at the 8 o'clock and records the vitals of the patient and executes the order. One day, one morning round, the resident doctor was taking around and he finds tablets in the palms of the patient's hand. The patient was dead. The nurse might have put the tablet in the dying patient and immediately the patient succumbed. So this happens once in a while. One patient was operated for hernia and was shifted to the ward. After about 4 hours, when the operation list was over, the OT team came for round. The operated patient was found dead in the bed. Means the patient was not monitored post-operatively, which should have been carried out. Pulse BP monitoring was done. It is a routine to shift the patient with the resident doctors. Herniatomy was planned for a 3-year-old child. He was shifted to OT with his mother. The junior resident took charge of the child. He had prepared the injections, atropine and scopolamine as pre-anesthetic medication. The child was kept on the shoulder of the mother and was given injection atropine intramuscularly. The child died after 10 minutes. The patient received injections scopolamine by mistake. Local anesthesia is the most dangerous anesthesia in my life. It can produce anaphylactic reactions, and there are no monitoring anesthetics. We take it lightly, this local anesthesia, so no problem. But that can produce anaphylaxis, and patient must have received atropine before doing any procedure when you are alone. There must be Anesthetist standby. One highly reputed surgeon, this is I'm talking about complications in VIP. VIP patients are somehow more prone to develop complications. One highly reputed surgeon performed laparotomy on a 1.5-year-old child for hypertrophic pyruvate stenosis. On 10th post-op day, complete SR was done. The patient had burst abdomen. The burst abdomen was resutured on emergency basis. Post-operatively, the patient develops intestinal obstruction, so the child was re-explored. On exploration, the child had small bowel stricture, which was excluded, which was excised. It is said that VIP patients are known to have more complications. I don't know what is your experience. This is true. That is called VIP phobia, foreign body removal. A piece of needle had pierced the palm of a housemaid accidentally while washing clothes. The surgeon tries to remove it under local anesthesia. The needle was not found at entry point. It had moved and was tagged and removed under IIT control. Lesson to learn. Foreign body may move in the tissue planes. One should not try to remove it under local anesthesia. It should be removed under IIT control. Continuing with the complacency and complications in surgery. In the past, Chevron was prepared in the glass bottle and stored in the dressing trolley. The color of the diluted Chevron is yellowish amber color. The MVI injection is provided in the glass ampule. It is mixed with the dextrose, 5% pint, or with single lactate pint and infused intravenously in the patient. The color of the MVI pint and Chevron bottles were same, amber color. So the resident doctors or paramedical staff on duty mistake pick up a Chevron bottle instead of MVI bottle and infusion was started. You know, the patient was collapsed immediately. So these mistakes must not be repeated, must be avoided, must have been avoided. Avoidable mistakes. One year, another example of complacency. One 11-year-old girl had a fall and sustained supracondylar fracture of the left humerus. She was taken to the consultant orthopedic surgeon. Close reduction was done. Plaster was applied in the arm in functional position. At night, patient complained of severe pain in the plaster arm. The plaster was not removed. Next day, the plaster was removed, but movements of the arms were decreased. The patient ultimately developed Walkman systemic contraction of left hand. Complacency is not seeing the patient frequently post-operatively. Lesson to learn: the plaster should have been removed immediately when the patient complained of pain in the plaster arm. Appendicular stumpitis. The patient was operated on for appendicectomy in the past. After a year or so, the patient develops pain in the right iliac fossa and vomiting, mimicking symptoms of acute appendicitis. This is said to be due to stumpitis, infection of the appendicular stump. So, how to explain to the patient, how to convince the patient? There might be different version of different surgeons, different consultants. The patient is convinced somehow that appendicitis can recur. Another similar patient was told that appendix can regenerate. Other patients are told that there might be more than one appendix. So we all know these are all wrong things. These are not correct. And we cannot believe that. But somehow the patients are convinced.